Well, hello everyone, and thank you so much for joining us today. Welcome, and thank you for joining this conversation with Dr. Anthony Fauci. He's director of the National Institute of Allergy and Infectious Diseases. Today's conversation will look at global aspects of the COVID-19 pandemic in Africa and elsewhere, and its interaction with the pandemics of AIDS, TB, and malaria. This is the first in a new series of web-based dialogues we'll be hosting titled Friends Health Chat. I'll ask a few questions of Dr. Fauci to start us off, and then we'll be taking questions from the audience. Please type your question in the Q&A box, and we'll get to as many of those as we can. Dr. Fauci, welcome, and thank you for making time to speak with us today.
Thank you, Chris. I appreciate you having me.
So you're a person who really needs no introduction, but I will just say that we've known you for decades as one of the foremost global leaders in HIV and infectious disease research. And we also know you as a scientist who has welcomed collaboration between researchers and affected communities and advocates. And that connection is one of the aspects of the HIV response that's made it so effective and so transformational. So thank you for a lifetime of leadership on HIV and infectious disease research.
Thank you. Thank you, Chris.
These days, when we see you, it's usually in your role as a member of the White House Coronavirus Task Force and as a prominent voice for science and evidence-based approaches to COVID-19 in the United States. Today, we want to have a conversation about global aspects of COVID-19 and also how it could affect efforts to address AIDS, tuberculosis, and malaria. And of course, these are all diseases where the United States has made considerable investment with our partners and implementing countries, and where up to now, we've seen great progress. So let me start off with our first question. Last week, a World Health Organization survey reported that COVID-19 is disrupting essential health services around the world, with low and middle income countries hardest hit. A Wall Street Journal story from 2 weeks ago said lack of testing makes it hard to know how real the status of what the real status of COVID-19 is in Africa. We've seen real leadership from many African governments and the Africa CDC during COVID-19. But what impacts are you seeing from COVID-19 in African countries and low and middle income countries generally? How are the dynamics of the pandemic different in those countries from in the United States?
Well, Chris, that's a very important question and something that we, in our discussions, we have a weekly discussion with, which is sort of umbrella sponsored by the WHO, in which representatives from all the countries throughout the world sort of compare notes about the impact of COVID-19 on their country. And one of the things that has insidiously crept up was, a few months ago, talking about the concern of what would happen when COVID-19 inevitably hits the developing world, particularly sub-Saharan Africa. And we followed it and heard from our colleagues in those countries. And a very interesting thing has evolved. First of all, at a time when we knew that there was COVID-19 there, it was really not being reported. And some people, I think, understandably but inappropriately said, well, maybe because of climates or what have you, you're going to see really very little impact in the southern African countries with COVID-19. And then became very clear that when there was enough capability of testing and identifying disease, that it has hit there the same way as it had hit all other 217 countries that has been involved. So the idea about sub-Saharan Africa being exempt is not the case. The interesting dynamics, which is the second part of your question, is that whenever you have a pandemic or an outbreak of the magnitude of what we are seeing with COVID-19, that intersperses itself in the dynamics of already ongoing other pandemics, such as HIV, TB, malaria, you start to see something that's really profound, and that is the interruption of services for those other diseases including things like drugs for HIV, bed nets for malaria, drugs and care for tuberculosis, that you have a rather substantial disruption of what prior to COVID-19 was working variably in a pretty good way in most of those countries. In the United States, there have been a number of studies to show the interruption of normal screening things like colonoscopies and mammograms and things like that have had an impact on the level of diseases that are mostly preventive, not necessarily responsive. Whereas in sub-Saharan Africa, we're interrupting the response to ongoing outbreak, namely HIV, TB, and malaria. One other thing, just to mention, that was, I think, misleading is that since the Southern African countries have a population that is much younger in general than the European Union and the United States populations, that you would expect that the lesser degree of serious disease among young individuals might make it look like there isn't as much COVID-19 in Southern Africa as there really is. What we're concerned is that sooner or later, when younger people infect younger people and then start infecting people with underlying conditions, that we're going to see the same sort of morbidities that we're seeing only a bit later because of the dominance of young people. So those are just some of the reflections in answer to your question about impact and dynamics.
I appreciate that. And let's go a little bit deeper on one aspect of that. There's predictions that the great majority of deaths related to COVID-19 in Africa could be caused by impacts of the virus on other disease responses, like you've said. And the AIDS, TB, and malaria epidemics, they still kill over 2 million people each and every year. And a recent Global Fund survey found that more than 3/4 of those programs have been disrupted as a result of COVID-19. So what do you see, what are you worried about as the potential long-term effect of COVID-19 on our efforts to tackle the AIDS, TB, and malaria pandemics, including among socially marginalized and key populations? And what do we need to be doing to mitigate that potential damage?
Well, Chris, I'm actually really concerned about, an extraordinary disruption of what we made investments in for such a long period of time. I mean, and what we're going to do about it, I'm not sure that there's an easy solution or answer to your question. I mean, I'd like to think of, okay, we're going to do A, B, and C, but, we were stretching the limits in some countries to get adequate responses to the triple threat of HIV, TB, and malaria. When you have the kind of projected disruption that we're talking about now, I'm not sure what we can do. I think we really do need, quite frankly, you don't want to say the answer is to have a conference to talk about it, but I think we really need to sit down with all the countries and figure out, in the context of what each of them are experiencing, what is their view about how we in the developed world can chip in to help them in that, because I'm not so sure that from our vantage point, at least, from the vantage point of looking at it from the task force in the White House coronavirus task force, that's not even on the radar screen when it really should be. So I'm trying to see if we can get some more attention to that. But I would welcome any suggestions, Chris, that I don't have a lot of really brilliant ideas about how we're going to address that.
Yeah, well, no, and that would be great to have more attention on it. Well, let me ask a question, and then maybe I can, put out some ideas too. But clearly, the international community needs safe and effective COVID-19 vaccine or vaccines, and to make that available globally and as soon as possible. What else does the world need to be doing right now? Things like testing, prevention, therapeutic interventions to address this new pandemic. And what's the danger if we don't scale interventions like that now?
Well, the danger is that we're going to have a substantial proportion of the world that doesn't have access to these lagging behind. So let's take all three: diagnostics, therapeutics, and vaccines. So right now, the diagnostics that we finally are getting to be able to be done on a broader scale, that with really a great degree of sensitivity and specificity, I think would be perfectly applicable to sub-Saharan Africa and the developing world in Southern Africa. And I refer specifically to the Binax Abbott Now, which is really a credit card type approach, very inexpensive, a high degree of specificity and sensitivity, like 98.5% sensitive and 98.5% sensitive and 97.5% specific. So it just seems to me, if you're in sub-Saharan Africa and you have fever, you don't know if it's TB or malaria or HIV or COVID, you could find out in 5 minutes for practically nothing. So the United States has bought 150 million of these single individual credit card approaches. That is just a single swab, stick it in, 15 minutes later, you get it. When I saw that come out, the first thing that came to my mind was, boy, we should order another 200 million of those and see if we can get them to the developing nations for diagnostics. But therapeutics, we really have a problem, Chris, because we have a couple of good therapeutics for advanced disease, people hospitalized either on ventilators or requiring oxygen. What we need for Africa is more upstream as opposed to downstream. We need drugs to keep people out of the hospital. And we don't have a lot of those direct antivirals. And one of the things I was just talking about this morning on our morning daily meeting is the need to get a HIV ART type drug for COVID, which you can give orally for a few days. You don't need to give it lifetime the way we do with HIV, but you just need in that window when people are either going to do fine or going to deteriorate and require hospitalizations. So we need to move on that. I don't think that that is necessarily, Chris, in the immediate pipeline, because we've done initial screening and initial repurposing, and there are not a lot of drugs like that. Remdesivir is one of them. We need to improve on remdesivir category of drugs. And then finally, the last is vaccine. One of the things that gives me, I would say, some encouragement and hope is that in all the negotiations that the federal government has had with the 6 or 7 companies that we're making an investment, either helping to develop, having our clinical trial sites be part of the phase 3 trials, or pre-purchasing considerable numbers of drugs, we're doing it way in excess of the number of vaccine doses that we need for the United States. For example, some of the companies, we've already pre-purchased hundreds of millions of doses, and several of the countries feel within a year they could get 1 billion or more doses. So if we get a few of the companies that are able to make 1 billion or more doses, then I think we can get an equitable distribution to the developing world and the lower and middle income countries.
Oh, that's very encouraging to hear. And worth noting that the Global Fund to Fight AIDS, TB, and Malaria actually right now has been providing funding to countries to get out, personal protective equipment, other prevention, testing, diagnostics, and when they're available, treatments, and actually can play a role in getting vaccines out when they're available. The concern is the Global Fund's COVID-19 response mechanism is running out of money. It's going to be out of money by the end of the month. So that is one of the conduits where we could get these life-saving things out to Africa and elsewhere, but it is running out of money right now. Well, let me, Dr. Fauci, step back for just a minute and ask you a more general question. COVID-19, we all know, is such a serious challenge in our own country, in the United States. Why should Americans care about how COVID-19 will affect African countries and low and middle income countries in general? Why should we care?
Well, I think we should care for the same reasons that we care about HIV, about tuberculosis and about malaria. Because I mean, I've always said, and you know that, and you have said the same thing, Chris, that we do have a moral responsibility as a country with riches who is investing hundreds of millions, if not billions of dollars to address this in our own country, that we have a moral responsibility to be concerned about those countries that don't have that capability. But there is also clearly an additional reason, and that's what we have been referring to in many situations as enlightened self-interest. And the enlightened self-interest is that this is a global pandemic of historic proportions. Unless you control a pandemic globally, you will not have controlled it anywhere. You can get it damped down, but if it's still raging in one part of the world, sooner or later, you're going to continue to seed wherever you are. And we just know that. I mean, that's how it started, from China to the other countries, and now it's essentially a truly historic global pandemic. So we have two good reasons to care about COVID-19 in African countries and other low and middle income countries. No doubt about that.
Thank you. Experts, including yourself, have long warned for years about the threat of infectious pandemics. And last month, you actually published a paper in the journal Cell noting that SARS, MERS, and COVID-19 are only the latest examples of a deadly barrage of coming coronaviruses and other emergencies. So how, from your perspective, can we ensure as a global community that we're better prepared for the next pandemic threat before it arrives? And how can we ensure health systems are better able to cope when faced with the next infectious disease threat?
Well, Chris, I mean, that's something that we've been talking about with a number of different outbreaks. And let me just briefly reiterate it right now. If ever there was a wake-up call of what we have been talking about the danger of emerging pathogens, particularly as we've seen clearly with COVID-19, when one perturbs the interface between the human and animal world, as we've seen with the wet market approach with bats and intermediate hosts. So there are about two or three things that I think we can do and we really do need to address. And I hope that we have good corporate memory so that when this is over, we don't move on to the next immediate problem and forget the fact that we need to prepare for this inevitably happening again. One is the building up of health systems. As you said, the requirement and the need for building up health systems long antedated COVID-19. We've been talking about that now for decades, and we really need to do a better job, both at the local domestic level and certainly at the international level with the global health security network that we spoke about and continue to speak about. That's one thing. The other thing, I think, is a much more of a purely scientific approach. I've been talking about, and my colleagues, I'm certainly not the only one who's been talking about it, about things that we can do in anticipation of the unknown. And one of them is advancing platform technologies. And I'll give you a good example of this, Chris. If you look at what we were able to do with a vaccine for COVID-19, when the sequence was put up on a public database by the Chinese on January the 10th, on the 15th, we were already involved in vaccine development. 62 days later, we had the first phase 1 trial, and 6 months later, we had the first phase 3 trial. That was something that usually would take about 4 years if you didn't have the platform technology to be able to do that. So we need to keep perfecting that. The other thing is prototype pathogens. So even though we get surprised with new pathogens, they fall into broad general classes. So if you really perfect everything you need to know about drugs, vaccines, or what have you, for example, the flaviviruses, which allowed us to be able to respond rapidly to Zika because of our experience with yellow fever and Japanese encephalitis. Because they're the same family of pathogens. So rather than take them as individual, take them as a class, which gets me to the thing that I'm just going to say because it's so obvious. We have been living with coronaviruses forever. There were 4 of them that cause about 15 to 30% of all of the common colds that we repetitively get in the winter. In 2002, we had the first pandemic coronavirus with SARS. Jump species from a bat to a civet cat to a human. 8,000 cases, almost 800 deaths. 10 years later, in 2012, we had MERS, the Middle East Respiratory Syndrome, which is still smoldering in Saudi Arabia. Now, in 2019, 2020, we have COVID-19. So somebody is trying to tell us we better develop a universal coronavirus vaccine because we've already in 18 years had 3 pandemics associated with coronaviruses. So those are some of the things we need to do. Health systems, prototype pathogens, and platform technology.
Really helpful, thanks. This question is meant in a way a little bit more personal, but also to you as a scientist for sure. I mean, you've spent much of your career fighting HIV in the United States and globally. So have I. And I wonder how you're feeling about our progress against HIV, the epidemic, and what we can learn from that response as we tackle COVID-19.
Yeah, that's a great question, Chris, because the situation with HIV, particularly in the arena of therapy, is a spectacular success story. And the reason it's a spectacular success story is because we put all the resources we possibly could into the fundamental basic science in understanding the replication cycle of the virus and targeting antiretroviral drugs to the point where we took a disease where, 30 some odd years ago, people were saying it's impossible. We'll never be able to treat this. This is a uniformly fatal disease. And now we see when people are put under adequate and appropriate therapy, they can actually lead normal, healthy lives. So I use that as the prototype example. If we can do that with HIV, we can do it with COVID-19. The other lesson from HIV is what we've been able to accomplish with PEPFAR and the Global Fund. What you've been able to do is to get a broad, global, highly funded response that has really, in many respects, transformed these diseases. So if we could borrow from and use the HIV model and apply it even in a modest way to COVID-19, I believe we could really turn this around and turn it around in a very, 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 I think, definitive way.
Great. Well, I've got one more question before we go to Q&A, and I think you're the only person on the planet who could field this question, so let me go ahead. But it's a 3-part question. But for each of these major epidemics, which again are with us year in and year out, AIDS, TB, and malaria, what do you see for the priorities for innovation in terms of our responses to those epidemics? And then what would you say are the real priorities for scale-up of interventions we already have? So for each of them, what's the innovation we need? What's a scale-up priority right now? Let's start with HIV.
Okay, so HIV, overwhelmingly right now, we need a vaccine. It is one of the most problematic issues because of the nature of the virus. But for me, that's really up front, and that's the thing that we hope we're going to be getting some modest success for, and then we can improve upon that. And that gets to your second question about scale. Once we get a vaccine, we need to make it globally available because I think we can put the nail in the coffin of HIV. Also, with HIV, I think what we really want is long-acting drugs so that people who get drug fatigue can do something like get an injection twice a year, and that's it. So we've got to look at preventing it and treating it because, we don't want to just get focused on an HIV vaccine. We have 36 million people living with HIV, And we want to get as user-friendly and scaled up a therapy that we possibly can get.
Great. So with TB, innovation and scale up.
TB, again, innovation, I hate to keep getting back to the same thing, but it still is the two things. You want to get a vaccine to prevent not only the acquisition of TB, but to prevent the activation of latent TB. Because remember, we have about 25 to 30% of the population of the world falls in the category of being at risk for activation. The other thing we need to do, because we do have a threat of extensive and multiply drug-resistant tuberculosis, we've got to have easy-to-administer drugs that are relatively short course that can be distributed widely. That's that.
And finally, innovation and scale up for malaria.
Well, again, falling in the same issue, malaria, like tuberculosis, it's interesting that we don't necessarily have good vaccines for things that the body itself doesn't make a particularly good immune response against. But if we can get a vaccine, and I think we can because we're making some good headway in that, in malaria, just think what you can do with malaria if you prevent the hundreds of thousands of deaths, mostly in African children. I mean, to me, that would be something that would be really a phenomenal goal. So those are the three approaches that I would take to those, diseases that are really, driving the disease process and the morbidity and mortality in the developing world.
Wonderful. Okay. Well, thank you very much for fielding all those questions and those great answers. Now we're going to go looking at questions in the Q&A box, and there's a whole lot of them. And they keep jumping around. I'm sorry, with every new one, the question jumps around. So let me just dive in. This comes from Selena. It's been very difficult to get global attention focused on pneumonia and other respiratory diseases in Africa. Is there a way to use this tragedy of COVID to focus on those issues?
I think that's a good question, because whenever you get a challenge of a particular disease, you should always think about the possibility as using it as an opportunity to essentially improve on those kinds of things that are related. I mean, because if COVID attacks as mostly acute respiratory distress syndrome in its advanced form, you might use that as a stepping stone to address a lot of other things, including the typical bacterial pneumonias, which are still killing a lot of children and adults, mostly children, in sub-Saharan Africa.
Right. This one comes from a wonderful civil society leader, Peter Van Ryan, and he's asking, let me see if I can get back to his question. Well, the gist of it was, and again, greatly appreciate all your work on the importance of working with civil society. But, looking forward, how do you think civil society can play a role in tackling COVID in low and middle income countries in Africa and in our own country? What's the civil society role here?
The civil society role, Chris, is exactly the civil society role that has been so successful, in getting at the community level, to getting people involved and making them to have access to the kinds of interventions, which is what we did very successfully with HIV. And I think we could use that as the model for COVID. I think particularly relevant as the questioner asked in the developing world.
Yeah. Here's a question from Rebecca Webb. Dr. Fauci, it'd be interesting to know if you think the development of a COVID vaccine will have any benefit for the HIV vaccine field, either in terms of what's learned about approaches being used or in terms of scale up of vaccine R&D capacity.
Well, maybe the latter, scale up of R&D capacity. I think from a fundamental scientific standpoint, they really are two extremely different approaches, for the simple reason that, lucky for us, vaccine efforts in COVID-19 are really based on knowing that the body can and does induce an effective immune response, given the fact that the vast majority of people, more than 85%, have either mild to modest disease, and the overwhelming amount, more than 90+%, recover completely. So if the body can mount an immune response that recovers completely, I wouldn't say it's easy, but it is highly likely that we are going to get an effective vaccine for SARS coronavirus 2. And as I've explained multiple times, that's just not the case with HIV, because we're going to have to do better than natural infection, because natural infection does not induce an adequate immune response against HIV.
Okay. And this question is, so from Dr. Carolyn Gomes, COVID has laid bare the health vulnerabilities are inextricably related to socioeconomic vulnerabilities. The HIV approach in recognizing these human rights has been critical to that approach. How about with universal health coverage? I mean, when you think as a scientist about being effective in terms of getting broader health systems, what's the role of socioeconomic determinants, human rights?
Critical. I mean, that's the reason why we have to have globally, literally universal health coverage. I mean, that's really essential. People have been speaking about that and working their entire lives on that well before COVID. And when you get a disease like COVID, looking even in the United States, we have, and I'll use this opportunity to bring it up because it is important, we have a significant disparity both in the incidence of infection and in the comorbidities that lead to a more severe outcome. And if you look at the statistics, Chris, I know you're aware of them, but we should state them, and you put up on the charts either the hospitalization per 100,000 population or the deaths per 100,000 population, comparing African Americans with whites in the United States, it's 3 to 5 times more in the African Americans, and in many respects to Latinx also, than the whites. To me, the social determinants of health are impacted very, very much by universal health coverage or not, because you wouldn't have so many of the things that you have in the African American community with diabetes, obesity, hypertension, chronic lung disease, kidney disease. If you had universal health coverage, you would mitigate that considerably.
Great, okay. And this question comes from an old friend of both of ours, one of the kind of founders of civil society advocacy on vaccines in our country, Bill Snow. And he's asking, what can the average person do? What can the average person in the U.S. do to encourage a global view and response with current urgency and local concern?
Yeah. Well, Bill, that's a great question. And what we need to do is to apply the same sort of essentially global responsibility as part of our responsibilities. As a nation, we did it with HIV, with PEPFAR and the Global Fund. And the average person in the United States has really got to get on board with realizing that, A, we live in a global community. And in the answer to a question that Chris asked me a few minutes ago, it's a combination that when you're dealing with a pandemic by its definition of the word pandemic means it's global. So it's going to affect us like it or not. But also, we really do need to hang on something that is distinctly part of our society and our culture. I hope we don't lose it. It looks like somehow it's drifting away, is that moral responsibility that we have to take a global view when it comes to diseases.
Yeah, thank you. This is from Jean-Francois Tardif. And the question is, what's the risk to developing countries if we fail to protect their health personnel from COVID-19? Is there a risk of that health systems are going to collapse?
Oh, absolutely. That is very, very clear. And it's interesting. So that triggers me to give you a response, which something you may be interested in. That very much like Ebola, the healthcare providers were the most vulnerable. Well, it's very interesting that the same holds true if you don't have the proper personal protective equipment. That healthcare providers in the United States are as vulnerable or more vulnerable to getting infected because of the proximity of a respiratory-borne illness of people breathing and sneezing and coughing and all kinds of things. But we have found, interestingly, that because of the availability of very good personal protective equipment, including all of the N95 masks and the shields and all the gowns and things, that the rate of infection among healthcare workers in the United States is less than the general risk in the population, even though they put themselves at risk every single day. So in answer to the question of the person who just put that question, we better make sure that in the developing world, we pay specific and strong attention to making available the proper personal protective equipment for the healthcare providers, because you can wipe them out really quickly if you don't do that, because it is a highly, highly contagious disease. And if you put healthcare workers trying to take care of ill individuals in a hospital setting without the proper personal protective equipment, right away you're going to run out of healthcare providers.
Great, thank you. And just to note, I think we have about 5 more minutes with you. I really appreciate the stamina, but you're used to this format, so I appreciate it. This question is from Camden Hoffman. Dr. Fauci, can you please address the balance of hard science and a focus on human societal behavioral change, given what we learned from all the other pandemics like Ebola, Zika, SARS, etc.?
Yeah, well, that's a great question as it applies to COVID. And that's behavioral change. You know, when you're dealing with Ebola and the understanding of things like touching, burying, hugging people who are sick or dead was one of the real driving forces of the outbreak of Ebola. When you're dealing with a situation that requires behavioral change, we in the United States have a significant issue that I'm very disappointed in. And that is when we were trying to so-called open up the country economically to get back to being some form of normality, at the same time that I and my colleagues spent a lot of time developing the guidelines for opening America again, namely the gateway, the phase 1, the phase 2, the phase 3. It was stunning to me, Chris, that in some states and cities and counties, you would see television clips of people crowded indoor at bars, which is a super spreading event if you ever saw it. And it really is interesting how human nature, with behavior that is clearly detrimental to the goal of containing an outbreak, particularly young people, because they perceive, in some respects correctly, that they likely are not going to get seriously ill. But what they forget is their societal responsibility to not propagate the outbreak, because if they get infected, they're likely going to infect someone else who then might infect someone who really is vulnerable and will have a serious, severe consequence.
Yeah, thank you. So this is from Jamie Bay Nishi. As NIH and other USG partners advance research on COVID-19 vaccine candidates, are you evaluating products for viability for use in low and middle income countries, particularly low resource settings? Example, live attenuated versus RNA vaccine, cold storage, delivery mechanisms, number of doses required. But that's just an interesting general question about, what are different considerations in terms of usage of vaccine in the United States and in low and middle income country settings? And what are you thinking about that?
Well, yeah, in some respects, yes. I mean, one of the things that's always an issue is the cold storage issue and the cold chain that is so often required. And we do consider that. And that's the reason why we've invested in multiple vaccine candidates. The other thing I mentioned a few minutes ago is some of the diagnostics to make sure you can get some that can be easily used in the field that don't require any equipment. And I refer specifically to the diagnostics that require RNA and amplification with PCR. Now we have tests that require no special equipment. Another thing that we did, not only because it was important in the United States, but we did it with the thought in mind that the developing world would really benefit greatly from that. So there are a couple of things that we are doing. Not all, I have to admit. Sometimes you do things that are only applicable to the developed country, but in some of them we do pay attention to that.
Great. From Eliza Waxman, Dr. Fauci, how do we ensure that evidence-based lessons learned from the COVID-19 response in the U.S. and globally are documented and lead to long-term policies on pandemic preparedness and response?
Well, Elisa, we do that every day. I mean, we do, the whole scientific process, if done correctly, is evidence-based. And when it's evidence-based, it's documented in the literature and it's documented in our common practices that we do. So I don't really have any issue that our COVID-19 response is not going to be ultimately documented so that we have pandemic preparedness later on. The one thing that bothers me is the amount of things that aren't evidence-based. And we've seen examples of that in the United States, like claims that certain drugs have a great positive effect when there's no scientific evidence whatsoever that they have a positive effect. And yet it gets ingrained, and I and my colleagues have to spend a lot of time trying to debunk that. And when you're in the middle of a pandemic and you're trying hard to address all the appropriate issues, it is truly a waste of time to have to debunk nonsense. But, unfortunately, we've had to do that.
Well, Dr. Fauci, we are very thankful you are there. Be doing that. And we're actually out of time. I know you're on a schedule, but I just want to thank you. This has been a wonderful conversation, really helpful. We'd always love to chat with you when you want to come back to talk about global aspects of this and other areas of global health. So thank you so much for your time, and thanks to everybody who joined and for your questions.
All right. Thanks a lot, Chris. I appreciate you having me. Good luck.
Take care. All right. Bye-bye.